Now let's start with the colonic polyps. So a polyp is a grossly visible protrusion from the flat mucosal surface of the intestine. Most polyps are benign. Classification of polyps. Number one, it is hyperplastic polyp. Most common non-neoplastic polyp in the colon arises from the hyperplastic mucosal proliferation. No further workup is needed. Hematomachous polyps include juvenile polyp, a non-malignant lesion generally removed due to the risk of bleeding, and Peutz Jeghers polyp, generally non-malignant. Adenoma, most common type of polyp found in the colon, present in approximately 30 to 50% of the elderly people. These polyps are potentially pre-malignant. However, less than 1% of such polyps become malignant. Most polyps are asymptomatic. Less than 5% of the patients have positive occult stool tests. The probability of an adenomatous polyp progressing into cancer can be judged clinically by the lesion's gross appearance, histology, and size. Adenoma can be sessile or stalked, that is pedunculated. So suppose this is a surface, and this is an adenoma, which is just raising upwards from the surface. This is a sessile polyp. I'm sorry, this is not adenoma. Adenoma. So suppose right now I'm talking about polyps. Polyps can be sessile and pedunculated as well. So this is a sessile polyp, and this one which has a uh, which has a stem associated with that, it is called as a pedunculated polyp. So these are pedunculated polyps and these are sessile, and same is true for the adenomas. This one is sessile adenoma and this one is pedunculated adenoma. Now let's move forward. Okay, let's do that. So the cancer is seen more commonly in the sessile polyps. Histologically, adenoma is divided into tubular, tubulovillous, and the villous variety. Villous adenomas are more common. Villous adenomas, which are most commonly sessile, the villous adenomas, which are most commonly sessile, are most likely 3 times more likely than the tubular adenoma for malignant transformation to become malignant among 3 variants. So villous is villainous. So the villous adenomas are most commonly sessile and they are more likely to become malignant. Second on the list is tubulovillous, followed by the tubular adenoma with the least risk of malignant transformation. Therefore, as the villous component increases, the risk of malignancy also increases. The likelihood of an adenomatous lesion containing invasive cancer also depends on the size of the polyp. The risk is negligible, that is less than 2% with less than 1.5 cm polyp, intermediate 2 to 10% with 1.5 to 2.5 cm size, and substantial 10% with the polyps more than 2.5 cm in size. Then now let's talk about Lynch syndrome. Lynch syndrome is also known as hereditary non-polyposis colorectal cancer (HNPCC). To aid its diagnosis, the International Collaborative Group of Hereditary Non-Polyposis Colorectal Cancer established criteria known as Amsterdam Criteria 1. At least 3 relatives with a colorectal cancer, one of whom must be a first degree relative of other. One of whom must be a first degree relative of the other. Involvement of 2 or more generations. At least one case diagnosed before age 50. Familial adenomatous polyposis has been excluded. HNPCC is also classically divided into 2 subgroups on clinical grounds: hereditary site-specific colon cancer, that is Lynch syndrome 1, and the cancer family syndrome, that is Lynch syndrome 2. The Lynch syndrome 2 is directly associated with a high risk of extracolonic tumors, the most common of which is endometrial carcinoma, which develops in up to 43% of the females in affected families, also associated with the ovarian and skin cancer. So over here you can see endometrial cancer screening with annual endometrial biopsy should begin at age 30 to 35. Ovarian cancer risk is also increased and may present at a relatively younger age in the patients who have Lynch syndrome. Therefore, the prophylactic hysterectomy and bilateral oophorectomy is recommended at age 40 or earlier if childbearing is complete. The next point is about the colorectal cancer. How do we screen for the colorectal cancer? The colon cancer screening in high risk patients, family history of adenomatous polyps or colorectal cancer, like in first degree relatives at age less than 60. We perform colonoscopy at age 40 or 10 years before the age of diagnosis in the relative, which comes first. Repeat every 3 to 5 years. Also repeat after 5 years if 1 to 2 small adenomatous polyps are found. So we did colonoscopy, and on colonoscopy we found 1 to 2 small polyps. Then we have to repeat the colonoscopy every 5 years. The next point is inflammatory bowel disease, including ulcerative colitis and Crohn's disease. These are also risk factors for development of colorectal cancer. begin 8 years post diagnosis, 12 to 15 years if disease only in the left colon. Colonoscopy with a biopsy every 1 to 2 years, and also of rectum. Then the next point is about familial adenomatous polyposis. It begins at age 10 to 12, and colonoscopy is done every year. And the familial adenomatous polyposis (FAP) is an autosomal dominant mutation in the APC gene. 100% risk of cancer if not appropriately treated with a proctocolectomy. The next point is about the hereditary non-polyposis colorectal cancer, also known as the Lynch syndrome. It begins at age 20 to 25. The colonoscopy is done every 1 to 2 years. The next point is about the colonic dysplasia. Increased risk of adenocarcinoma and prophylactic colectomy is advised, normally done in all patients who are more than equal to 50 years. Method of screening. Screening can be performed using high sensitivity fecal occult blood testing annually, flexible sigmoidoscopy every 5 years combined with FOBT every 3 years, or colonoscopy every 10 years. Colon cancer screening. Patients at average risk. General population start screening at age 50. So patients at average risk is general population. Every person is at general risk of colon cancer, and single first degree relative at age more than 60 with colon cancer or adenomatous polyps. Start the screening at age 50. Options include colonoscopy every 10 years. What is GFOBT? FOBT is fecal occult blood testing, but what is G? I don't know. So FOBT or FIT every year, FIT DNA every 1 to 3 years, CT coronography every 5 years, and flexible sigmoidoscopy every 5 years or every 10 years combined with annual FIT. Patients at increased risk. First degree relative age less than 60 with colon cancer or adenomatous polyps, more than equal to 2 first degree relative with a colon cancer or adenomatous polyps at any age. The colonoscopy at age 40 or 10 years before the age of cancer diagnosis in a relative, whichever come first, and repeat every 3 to 5 years. Next point is about colonoscopy is generally considered a gold standard test, but patients often find necessary bowel preparations unpleasant. Flexible sigmoidoscopy requires less preparation and is an acceptable alternative. If findings are normal, it should be repeated every 5-year interval or 10-year intervals if combined with annual fecal immunochemical testing. However, sigmoidoscopy does not visualize the proximal colon and is less sensitive than the colonoscopy. Increased risk for advanced neoplasia in the proximal colon is seen. Large, more than 1 cm adenomatous polyp, multiple adenomatous polyps, and polyps with villous or tubular-villous morphology. Therefore, all the patients who have such polyps detected on sigmoidoscopy should have visualization of entire colon with colonoscopy. They should have visualization of the entire colon with colonoscopy. The next point is follow-up colon after polypectomy. In terms of follow-up colonoscopy after polypectomy, small rectal hyperplastic polyps, we should perform polypectomy. We should perform follow-up colonoscopy after small rectal hyperplastic polyps after 10 years. 1 or 2 small less than 1 cm tubular adenomas 5 years. 3 to 10 adenomas, any adenoma more than 1 cm, or adenoma with high grade dysplasia or villous features, we should perform the colonoscopy after 3 years. Then more than 10 adenomas less than 3 years considered underlying familial syndrome, and larger more than 2 cm sessile polyps removed by a piecemeal excision. Polyp with adenocarcinoma must have minimal invasion and more than equal to 2 millimeter margin. So every 2 to 6 months or 2 to 3 months we should repeat the colonoscopy if we have more than 2 cm sessile polyp that is removed by the piecemeal excision. The next point is about the adenomatous colon polyps are considered to have malignant potential. Although not all adenomatous polyps will become malignant, they may demonstrate a typical progression from dysplasia to carcinoma in situ and finally adenocarcinoma. Patients at average risk are advised to undergo screening colonoscopy at 10-year interval, but patients with adenomatous polyps are at increased risk for future colon cancer and require more frequent follow-up colonoscopy. Management for the adenocarcinoma arising in a polyp is dependent on its pathologic features. Most cases of adenocarcinoma require surgical resection. However, if the invasive adenocarcinoma is in the head of the polyp, the margins are uninvolved, more than 2 millimeters. The lesion is well differentiated and there is no lymphovascular invasion. The patient can usually undergo non-operative management. Patients should be advised of treatment recommendations after careful consultation on a case-by-case basis. In patients who are managed non-operatively, follow-up colonoscopy should be performed in 2 to 3 months to exclude residual or recurrent disease. This short interval follow-up can also assess for a synchronous lesion that may have been missed. The endoscopist can tattoo the area of polyp at the time of initial biopsy so that the area can be found easily in the future. Subsequent follow-ups should be obtained 1, 4 and 9 years following the initial polyp resection. The next point is about cirrhosis. The cirrhosis, and now let's talk about the signs of liver cirrhosis. The very first sign will be jaundice. Then portal hypertension will present with esophageal varices, splenomegaly, ascites, caput medusae, hemorrhoids. Hepatic synthetic dysfunction will lead to ecchymosis and edema. Ecchymosis because there is decreased clotting factor formation, and edema because there is decreased albumin synthesis. Hyperestenism will lead to formation of spider angiomata, gynecomastia, loss of pubic hair, testicular atrophy, and palmar erythema. So, in this blog, they are saying that in the patients with cirrhosis, spider angiomas and palmar erythema both arise from the hyperestenism due to the impaired hepatic metabolism of circulating estrogens, a process that begins in the cytochrome P450 system. Circulating estrogen affect the vascular wall dilation. Spider angioma consists of central dilated arterioles surrounded by smaller radiating vessels. Palmar erythema is a result of increased normal speckling of the palm due to increased vasodilation, especially at the thenar and hypothenar eminences. Cirrhosis, especially due to alcoholic liver disease or hemochromatosis, can cause hypogonadism due to primary gonadal injury or hypothalamic pituitary dysfunction. Over here they are saying that the liver produces serum binding proteins for the thyroid hormones. For example, thyroxine binding globulin, transthyretin, albumin, lipoproteins. Cirrhosis leads to decreased synthesis of these proteins, which lower the total thyroid triiodothyronine T3 and thyroxine T4 in circulation. However, the free T3 and T4 levels are unchanged, and TSH will be normal, reflecting a euthyroid status. Here they are writing that individual intervals of FU colonoscopy, intervals for what is FU? I don't know. Colonoscopy after polypectomy. Okay, so they are not talking about cirrhosis; they are talking about polypectomy here. Intervals of FU colonoscopy after polypectomy: small rectal hyperplastic polyps, 10 years. Then 1 to 2, less than 1 centimeter tubular adenomas, it is 5 years. 3 to 10, more than 1 centimeter with high grade dysplasia of villus features, it is 3 years. More than 10 adenomas, it must be done in less than 3 years. Larger, more than 2 centimeters sessile polyps removed by piecemeal exceeded 2 to 6 months. And polyp with adenocarcinoma must have minimal invasion of more than 2 millimeter margin. So we do it after 2 to 3 months. It is the same table that we read on the previous page. Invasive adenocarcinoma is in the head of the polyp. The margins are uninvolved, more than 2 millimeter. The lesion is well differentiated and there is no lymphovascular invasion. The patient can usually undergo non-operative management. Now let's come back to cirrhosis. So the most common causes of cirrhosis are as follows. Clinical clues for common etiologies of the cirrhosis. More common are chronic hepatitis B or C viral infection, intravenous drug use, blood transfusions, multiple sexual contacts. They can lead to both of these viral conditions like hepatitis B and C. Both of them can be caused by IV drug use and blood transfusion and multiple sexual contacts. Alcoholic liver disease, excessive alcohol intake, non-alcoholic fatty liver disease, diabetes, obesity or metabolic syndrome. Hemochromatosis, family history of cirrhosis, history of diabetes, bronze skin appearance and high transferrin saturation. The next is less common causes. Number 1 is autoimmune, family history of cirrhosis, history of other coexisting autoimmune disorders, for example thyroiditis, anti-smooth muscle, liver, kidney, microsomal type 1 antibodies. Primary biliary cirrhosis, more common in women, fatigue, pruritus, elevated alkaline phosphatase, positive antimitochondrial antibody. Primary sclerosing cholangitis is associated with an inflammatory bowel disease. Alpha-1 antitrypsin deficiency, coexisting lung involvement and family history of cirrhosis. Cardiac cirrhosis, which is coexisting right-sided heart failure, will be there. Medications like methotrexate and isoniazid is present. They can lead to cirrhosis. Then Wilson's disease, family history of cirrhosis at young age and cassette fracture rings in the eyes can also lead to cirrhosis. Alcoholic hepatitis, AST more than ALT. In alcoholic hepatitis, the AST to ALT ratio will be 2 to 1, more than 2 to 1. In non-alcoholic fatty liver disease, ALT will be more than AST, right? So L is for the lipids. If AST is more than ALT, it is if AST is more than ALT and NAFLD suggests the progression to advanced fibrosis and cirrhosis. Now, normally if you are talking about alcoholic hepatitis, the AST is more than ALT, right? But if you are talking about non-alcoholic fatty liver disease, it is ALT which is more. But if it is NAFLD, patient does not have any history of alcohol consumption and he is having AST more than ALT, it means that it is progression to the patient has progressed to advanced fibrosis and cirrhosis. Now the next point is, if the patient has mildly abnormal LFTs, obtain the drug and alcohol history, family history, blood transfusion history, travel outside the United States, high risk sexual practices. If taking drugs or alcohol, discontinue offending agents, repeat LFTs, still they are higher after 6 months, that is chronic. Test for hepatitis B and C, hemochromatosis, iron studies, HFE protein analysis, fatty liver. If they are unremarkable, search for the muscle disorders like polymyositis and thyroid disease. Drugs that increase the LFTs: NSAIDs, antibiotics, HMG-CoA reductase inhibitors, anti-epileptic drugs, anti-tuberculous drugs, and herbal preparations. The clinical features of cirrhosis. We have done that, right? No. Okay, so clinical features, those were the etiologies. Now we are going to talk about the clinical features of cirrhosis. So symptoms, they can be asymptomatic or with non-specific symptoms. For example, anorexia, weight loss, weakness, fatigue, and muscle cramps, jaundice and pruritus, gastrointestinal bleeding, for example, melena and hematemesis, encephalopathy, for example, confusion and sleep disturbances. Women will have amenorrhea or irregular menses due to anovulation. Men will have hypogonadism, for example, decreased libido, erectile dysfunction, loss of axillary and pubic hair. They are more common in cirrhosis due to the alcohol or hemochromatosis. Physical examination includes skin, telangiectasias and caput medusae. On chest there will be gynecomastia, usually bilateral but can be unilateral as well. On abdomen we will find ascites, hepatomegaly and splenomegaly. The genitourinary system will show testicular atrophy. Extremities will show palmar erythema, Murex or Terry nails. Dupuytren's contractures and clubbing will be present in the cases of cirrhosis. Yeah. Then hypogonadism is due to either primary gonadal injury or hypothalamic pituitary dysfunction. Liver responsible for making serum binding proteins that will lead to liver dysfunction. Decreased serum binding proteins decrease total T3 and T4 almost as most T3 and T4 is in the bound form, and normal free T3 and T4 and normal TSH will be there, because the TSH is affected by the free T3 and T4, but the total amount of T3 and T4 will be affected by the bound form of the T3 and T4. So this is how it works. All cirrhotic patients should undergo surveillance ultrasonography every 6 months to exclude any liver mass irrespective of the cause. Now we should talk about the MELD score. The most commonly used calculation to predict the mortality in the patient with the liver disease is the model for end stage liver disease score, that is MELD score. The value used to calculate a score are serum bilirubin (INR) and serum creatinine. Sodium was recently added to calculation to improve the predictive value. The MELD score can be used to determine the patient's 90-day survival and to calculate the patient's priority on the liver transplant list. Patient with a higher MELD score take precedence should a suitable donor liver become available. Child Turcotte Puig score. So child Turcotte Puig score is used for 1 to 2 year survival. It uses objective like total bilirubin, PT-INR, serum albumin, and subjective variables like ascites and hepatic encephalopathy. The child Turcotte Puig score has largely been replaced by the MELD score, which relies on the objective variables only and is applicable along a broad continuum of the disease. Now let's talk something about ascites. So ascites, the common causes of ascites include extraperitoneal causes, which include cirrhosis, acute liver failure, alcoholic hepatitis, Budd-Chiari syndrome, heart failure, hypoalbuminemia, malnutrition, and nephrotic syndrome, and the peritoneal causes, which include malignancy, ovarian and pancreatic, and infection like tuberculosis and fungal. Evaluation. Diagnosis is confirmed by clinical, laboratory and radiological evaluations. Abdominal ultrasound needed to evaluate for the complication, for example splenomegaly and hepatocellular carcinoma. Paracentesis is recommended in the new onset ascites to determine the etiology. Liver biopsy is required if diagnosis of cirrhosis is unclear or will alter the course of management. Then we have abdominal paracentesis. Ascitic fluid analysis is most reliable way to differentiate between the different causes of ascites. The most common cause of ascites in the United States is hepatic cirrhosis. The differential diagnosis of ascites can be narrowed down by calculating the serum ascites albumin gradient, that is also known as SAG. So serum ascites albumin gradient can be calculated, which is equal to the serum albumin value minus the ascitic fluid albumin value. Note the ratio of the two. So it is the difference between the serum albumin and the ascitic fluid albumin value. The SAG value is useful in identifying the presence or absence of the portal hypertension and has replaced the old transudative exudative model of classifying the ascitic fluid. A SAG value more than 1.1 grams per deciliter is known as high albumin gradient ascitic fluid and indicates the portal hypertension, while a value less than 1.1 gram per deciliter is known as low albumin gradient ascitic fluid and indicates that the patient does not have a portal hypertension. Clinical conditions associated with high SAG more than 1.1 grams per deciliter include congestive heart failure, cirrhosis, and alcoholic hepatitis. Conditions associated with a low, that is less than 1.1 grams per deciliter albumin gradient include peritoneal carcinomatosis, peritoneal tuberculosis, nephrotic syndrome, pancreatitis, and serositis. The patient has SAG of 0.6 grams, so the patient in the question stem from which the discussion has been copied in the notes, the patient had a SAG of 0.6 gram per deciliter, that is 2.8 minus 2.2, which indicates non-portal hypertensive etiology of the ascites. Given clinical presentation, carcinomatosis from malignancy such as ovarian cancer would be a likely etiology. So she should have further investigation to confirm the diagnosis. Budd-Chiari syndrome is one of the post-sinusoidal non-cirrhotic causes of the portal hypertension and is caused by thrombosis of the hepatic veins and or suprahepatic inferior vena cava. The SAG value in the patient with the Budd-Chiari syndrome is more than 1.1 grams per deciliter. The next point is about ascites fluid characteristics. The color, bloody ascitic fluid can be caused by trauma, malignancy or TB, but the TB is a rare cause of bloody ascitic fluid. Then the second one is milky ascitic fluid, that can be chylous or pancreatic. The turbid one is because of possible infection. Straw colored is likely more benign causes. Okay, the neutrophils, if they're less than 250 per millimeter cube, so there is no peritonitis. If they are more than equal to 250 per millimeter cube, peritonitis is present, secondary to spontaneous bacteria. Spontaneous bacterial infections. Total protein more than 2.5 grams per deciliter, high protein ascites. Congestive heart failure, constrictive pericarditis, peritoneal carcinomatosis, TB, Budd-Chiari syndrome, fungal, for example, coccidioidomycosis. Less than 2.5 grams per deciliter, low protein ascites, cirrhosis, nephrotic syndrome. SAG, if it is more than equal to 1.1 grams per deciliter, it indicates a portal hypertension. Cardiac ascites, cirrhosis, and Budd-Chiari syndrome. If it is less than 1.1 grams per deciliter, absence of the portal hypertension will be there, and the etiologies can be TB, peritoneal carcinomatosis, pancreatic ascites, and nephrotic syndrome. So, when there is portal hypertension will lead to increased capillary hydrostatic pressure, decreased liver synthetic function, and indicated by decreased serum albumin, which can cause edema in the later stages of liver failure and increase PT and INR. In absence of portal hypertension, the ascites is caused due to increased capillary permeability. Then treatment of ascites, serum sodium and water restriction, 2 liters per day. Direct diuretic therapy if needed, start with spironolactone. When maximal dose of spironolactone fails to improve, add loop diuretic like furosemide. Aggressive diuresis more than 1 liter per day not recommended. Because of risk of hepatorenal syndrome. So we can't give aggressive diuresis because there is a chance of hepatorenal syndrome. Does not respond. If the patient does not respond to our treatment, we are doing sodium and water restriction, we are giving the diuretic therapy with spironolactone, we are giving the loop diuretics, but if the patient is not responding, we slow tapping of 2 to 4 liter per day of ascitic fluid with or without albumin infusion, but renal function is regularly monitored. Less aggressive paracentesis in patient with borderline renal function is done, because in any case if there is decreased blood flow towards the kidneys, there will be the development of hepatorenal syndrome in these patients. Hepatic hydrothorax, pleural effusion due to ascites, due to defect in the diaphragm. Right sided is more common due to less muscular hemidiaphragm. So hepatic hydrothorax is more common on right side because of less muscular hemidiaphragm will be there. Best option for treatment is liver transplant. The primary treatment is thoracocentesis followed by diuresis and salt restriction. No response. So primary treatment thoracocentesis followed by the diuresis and salt restriction. If there is no response, you should go for transjugular intraperitoneal intraperitoneal. No, it's not intraperitoneal, but it's TRIPS procedure. Transjugular intra. Uh, I don't know the meaning of P, but it is a shunt which is placed between the portal vein and the hepatic vein. So intrahepatic portal shunt. It is, I guess it is transjugular intrahepatic portal shunt. Yep. TRIPS is contraindicated in the pleurodesis. I will have to see the meaning of pleurodesis. So surgical portosystemic shunts have more morbidity. Okay. Chest tube placement should be avoided as it can result in the chest tube placement should be avoided as it can result in large volume protein, fluid and electrolyte losses as well as other severe complications, for example renal failure. Here you can see due to thinner diaphragm and more porosity chances on the right side, thoracocentesis recurs, thus loop diuretic, spironolactone and salt restriction should be done. Now let's talk about esophageal varices, which is a complication of hepatic cirrhosis. So bacterial infections can develop in up to 50% of the patients who are hospitalized for acute variceal bleeding. Therefore, these patients should be treated prophylactically with antibiotics. The preferred regimen involves the use of fluoroquinolone, ofloxacin, norfloxacin or ciprofloxacin agent for 7 to 10 days. So here you can see that liver cirrhosis and portal vein obstruction. Let me zoom it out. So this is a cirrhotic liver and this one is the obstructed portal vein. That obstructed portal vein has led to increased pressure in the left gastric varices and okay, so these are the esophageal varices in the gastroesophageal junction, like with at the site of esophageal variceal formation. Normally what is happening there, that there is a anastomosis between the left gastric artery and the I don't remember the other branch. The left gastric arteries, which are a tributary of the portal vein, and there are some tributaries of the azygous vein. I don't remember the name of that. I guess these are esophageal veins or something. So, but those there is a portosystemic anastomosis over there, and whenever there is portal hypertension, that leads to the formation of these variceal dilations. So, this is the splenic vein over here. These are the fundal varices and left gastric varices and esophageal varices. Here you can see the inferior mesenteric vein and superior mesenteric vein. Variceal hemorrhage develop in 1/3 of the patient with the esophageal varices, and varices occur in almost 50% of the cirrhotic patients. All patients with cirrhosis should undergo diagnostic endoscopy to exclude varices, determine risk of variceal hemorrhage, and indicate strategies for the primary prevention. Now, what is the prophylaxis? Small non-bleeding esophageal varices, all the patients should receive the prophylaxis. First line is non-selective beta blockers, for example propranolol or nadolol. They decrease the risk of progression to large varices and variceal hemorrhage, improve mortality due to bleeding, and overall mechanism of action is that decreased beta-adrenergic vasodilated response in mesenteric arterioles will lead to unopposed alpha-mediated vasoconstriction and decreased portal venous flow. Second line is endoscopic variceal ligation in those with the contraindication to beta blockers. The choice of beta blockers or endoscopic venous ligation depend on the patient preference and the size of varices. Endoscopic variceal ligation is preferred for the larger varices. Now here you can see treatment of variceal bleeding. The treatment of variceal bleeding is done by the endoscopic sclerotherapy. If it has no role in prophylaxis, octreotide can also be given. Long-acting somatostatin analog decrease the glucagon and decrease the release of vasodilator hormones. Splanchnic vasoconstriction and decrease the portal blood flow. Treatment of active variceal bleeding, no role in prophylaxis. What are the steps? Number 1, prompt and aggressive fluid resuscitation should be first step in management. All patients in acute hemorrhage should have vascular access established immediately with at least 2 large bore intravenous lines. Once appropriate vascular access has been established, first resuscitation with a crystalloid should be undertaken while any necessary blood products are prepared for transfusion. For example, packed red blood cells transfusion to maintain the hemoglobin at least more than 7 grams per deciliter. In addition, patient's airway, vital signs, cardiac rhythm, and urine output should be closely monitored. Patient with a UGIB, what is that? Uh, okay, that will come later on. But patient with a UGIB should also receive acid suppression with intravenous proton pump inhibitors and have all oral intake restricted. All oral intake restricted. Upper gastrointestinal. Okay, so the patient have upper gastrointestinal bleeding, upper GI bleeding. They should also get acid suppression with intravenous proton pump inhibitors, and all the oral intakes must be restricted. An octreotide infusion should be considered in the suspected variceal bleed. Once the patient are stabilized, upper endoscopy should be performed to identify and control the source of hemorrhage and to prevent the recurrent episodes. In approximately 50% of the cases of variceal bleeding, the hemorrhage ceases on its own without further intervention. This rate is significantly lower than seen in the upper GI bleeding to other causes, which approaches to 90%. Okay, so we'll continue with this algorithm in the next session. Okay, we'll continue with the algorithm in the next session. Until then, Allah Hafiz, fi amanillah, and take care.